Hello again. My name is Toby Richards and I'm a senior lecturer in surgery, and I have an interest in the management of iron deficiency, either with or without anemia, and the impact and efficacy of iron therapy in those patient groups and differing patient groups. This lecture is about how to diagnose anemia and iron deficiency in the preoperative patient and the options that are available to you to treat that. And I want you to bear in mind the difference between efficacy and effect. Just because someone has iron deficiency anemia, does that mean that you have to have a specific intervention to treat the iron deficiency anemia, i.e. the use of intravenous iron or oral iron to treat iron deficiency, the efficacy being to correct the iron deficiency? Or should you implement a program of care that covers all aspects of anemia and transfusion that has an effect on the patient that is not necessarily individually efficacious? And I'll let you work out what I'm trying to say there. So the first step is, if someone has a low hemoglobin, how do you define that anemia? I took a research fellow and I put them in pre-assessment clinic for 4 months. And of 1,500 people that came through that pre-assessment clinic over the 4-month period, we got every single one of their blood tests and sent every single sample off for a detailed analysis. We then followed those patients up throughout their hospital stay and up to 30 days. We divided this into patients who stayed in hospital more than 48 hours. Because we found that not a single patient under 48 hours received a blood transfusion, and most of these cases were minor procedures. That raises another definition of what is major surgery, and how should you define that? An operation over an hour, an operation that means a patient needs more than 2 hours in hospital, an operation where a patient needs high dependency. And in its own right, that definition of major surgery poses more questions. And so there's one question for you at the start of this lecture. What we showed is in people undergoing significant surgery, if you had preoperative anemia, which was prevalent in 30% of people, you were more likely to need a blood transfusion, so about 2.5 times more likely, and on average you receive 3 units of blood compared to 2 units of blood. Nothing new there. Preoperative anemia is associated with an increased risk of transfusion. With the results of the serum from these samples, these are the results. We showed that true absolute iron deficiency, as defined by a low MCV and a low MCH and a low ferritin, was present in 3 of 1,500 patients. Therefore, according to your textbooks, the other 1,500 patients, minus those 3, had anemia of chronic disease. That's of no help to us whatsoever. Because anemia of chronic disease is a dustbin diagnosis. It's a diagnosis made when you can't find a specific cause for the anemia, i.e. B12 folate deficiency, myelodysplasia, bone marrow failure, or iron deficiency. So in 99% of people undergoing surgery, that means we can't do anything. But what we need to do is expand our minds to what the diagnosis is, and expand our minds to the pathways of iron and iron metabolism. And I would propose, currently, in 2015, that a ferritin of less than 100 or transferrin saturations of greater than 20% would be appropriate for the use of intravenous iron in this patient group. And the next couple of slides will explain why. A key feature of this is the effect of inflammation. Now, if you take this study, we showed a direct correlation between CRP levels and hemoglobin. This slide is taken by work from Gunther Weiss and Lawrence Goodenough, published in the New England Journal of Medicine about 8 years ago. The slide is an exact copy of their work, and I know Gunther Weiss and Lawrence Goodenough well enough that we have the rights to produce this. Now, what you're seeing here in the top right hand corner, area A, is inflammation, or if you're using an animal model, injectable lipopolysaccharide. This activates a protein from the liver called hepcidin. Hepcidins are made up of 5 subcomponents, but essentially the active component serves to block a protein called ferroportin that prevents translocation of iron from inside of a cell to outside of the cell. Consequently, in the gut, at the second and third part of the duodenum, oral iron can be absorbed into the enterocyte but cannot be exported. Ferroportin is shut down, so it doesn't matter how much iron you pour into the mouth, it won't be absorbed into the bloodstream. Further, the macrophages and the reticular endothelial system that process broken down red cells will take up iron and store it as ferritin, and ferritin is effectively a cage. So you've got all the iron molecules inside, up to 3,000, surrounded and maintained in a ferritin. That ferritin is predominantly stored in the liver, and the circulating ferritin found in macrophages and the blood can be measured on your blood sample. Effectively, as a consequence of the failure to export iron by the hepcidin-ferroportin axis, those ferritin levels will increase, but you can't do anything with it because it's caged and enclosed. Further, with the effect of inflammation or lipopolysaccharide, erythropoietin production is downregulated. Consequently, your bone marrow is starved of the drivers and the substrates to make red cells, and you get poor quality red cells that are larger, more hypochromic than normal, that don't last as long. And so although your ferritin levels are high, and although the cells have iron within them, the bone marrow is functionally starved of iron, and this is a process of functional iron deficiency. That your blood markers may be artifactually high because they're an acute phase response, but you can't utilize or take up any iron. So how do we prevent anemia? This is your standard makeup, and what you're seeing here is heme iron supplemented with vitamin C and lysine, the ideal means to absorb oral iron. But it's of no use to our patients. It's very good for me, the surgeon, but it's no use to our patients the night before surgery. A pivotal trial in this area was undertaken by Stefan Anker called the FAIR-HF, and he coined this phrase, absolute iron deficiency and functional iron deficiency. It's not his work, it's not his definition, but this is the first study in a randomized controlled trial that used functional iron deficiency as a definition. And therefore there is level 1 evidence for that definition, and these are the definitions given. What they did was they took a population of patients with stable heart failure. So these are New York Heart Classification 3 or 4. They found that some 20% of this patient group had iron deficiency, whether or not it was absolute or functional. They then randomized these patients on a 2-to-1 ratio between intravenous iron and placebo. And the results are here. What you can see is predominantly quality adjusted life year results. You see the self-reported patient global assessment, i.e. what did the patient feel? Did the patient feel better? Compared to controls, yes, they felt much better. Interestingly, their New York Heart Classification also improved. Functionally, their 6-minute walk test improved. And for a 6-minute walk test, apparently 50 meters is what functionally makes a difference. And the average improvement here was 60 meters. Also, their EQ5D was significantly improved. My question to you again here is, what is the EQ5D? And how, in what ways can you use it in randomized controlled trials? It's a very well-validated endpoint, and it's used in a variety of different settings. What does EQ5D stand for? And what can you use it as a tool to measure? So across this study, what they showed was if you take a group of stable people with a chronic disease, and anemia a chronic disease, but you relabel them or redefine them as having functional iron deficiency and treat them with intravenous iron, therefore bypassing that hepcidin-ferroportin blocking mechanism, you can improve the patient's welfare. And these results now have been validated in the CONFIRM-HF study, And in the CONFIRM-HF, they also showed that readmission rates and mortality in heart failure was reduced by the long-term use of intravenous iron. Now, from the surgical perspective, this is all very well. Stefan's done a wonderful job. He's made people feel better. Not particularly helpful for us in perioperative medicine. In perioperative medicine, the fitter you are before your operation, the better you do. Consequently, if we take a people or a population that's analogous to this and we enhance them prior to the surgery, do we enhance their likelihood of having no morbidity and no mortality and no disability as a consequence of the surgeon operating on them? Bear in mind, elective surgery is deliberate planned harm to a patient. What is the evidence for intravenous iron? The main group in the world that has used this is the Spanish group led by Manuel Munoz, Jose Garcia Eche, and Elspeth Bisbey. It's a network of hematologists throughout Spain who've worked together and collaborated, pooling their results. And they've given different preparations of iron in different populations prior to surgery. Whether or not this is iron sucrose, which are maximum dose of 200 milligrams at a time, or iron carboxymaltose, which you can give 1,000 milligrams in one large dose over 15 to 30 minutes. What you can see is that anemia in this patient population prior to surgery was corrected in about 60 to 70% of people, and the average rise in hemoglobin is about 1 to 2 grams per deciliter in this patient population. What's interesting about this is the more anemic you are, the better your response, and this can be seen in all populations undergoing surgery. So intravenous iron appears to be efficacious in correcting iron deficiency and effective in correcting anemia, no matter how anemic you are prior to surgery. We've done the Cochrane analysis, taking all randomized controlled trials, and we looked at the impact of iron therapy in adults without renal failure. We showed that the final hemoglobin in the published trials was higher in intravenous iron compared to oral. Notice my words there, and you should read the abstract of the Cochrane review because the wording is very specific. We also showed that intravenous iron resulted in a higher hemoglobin at termination of those studies on meta-analysis compared to control. And the results are not as dramatic as you think. And I go back to my first lecture where I said that even a small degree of anemia impacts outcome. And what you're seeing is the anemia being corrected by only 1 to 1.2 grams in most studies that have been published to date. So it's not a huge difference, but it appears to be a difference that will correct anemia in 60% of people. What we also showed was that intravenous iron has no effect on correcting blood transfusion. Now, the reason I say that is if you look at the confidence intervals of this, they're very wide. The data from trials to date show that oral iron reduces transfusion in the perioperative setting. There is no current data that supports the use of intravenous iron to prevent transfusion in any population, whether or not that's perioperative or any other population. So although it seems like a very sensible idea, there is no proof, no level 1 evidence that this is what it's efficacious at doing. Now, that's probably because good quality clinical trials haven't been done with the correct endpoints. So we have designed the PREVENT study, which is a randomized controlled trial to assess the use of intravenous iron in patients undergoing major surgery. The inclusion criteria is major elective open surgery, and you're recruited 10 to 42 days prior to operation, and the reason is that intravenous iron needs ideally 3 weeks for maximal effect, but you will get 50% effect within a week, 80% effect within 2 weeks, and 3 weeks the maximal effect. Once they've had informed consent, they're then randomized between intravenous iron or placebo. It's double blind, so neither the patient knows nor the assessor knows what the treatment is. The way in which we do it double blind is that the intravenous iron is a black solution, so it's put into a black bag through a black giving set, and there's a curtain covering the arm of the patient while they get the infusion. And there are different ways to achieve blinding to avoid the bias that you would get from an unblinded trial. Again, I'm sure you'll be getting lectures on bias, but bias is very pivotal to the design of a randomized controlled trial. And what you don't want is any form of bias impinging on your results. The important characteristic to this study is that the inclusion is a hemoglobin that is less than normal, and we're not doing any baseline variables whatsoever with regards to iron studies. So, as this talk was given to surgeons, I've got show me the money. If you go back to this original slide on enhanced recovery after surgery, the objective of the government in the United Kingdom from the enhanced recovery program is to reduce length of stay by 1 day in 4.51% of the population undergoing surgery. If we're correct that we can correct anemia in 60% of people undergoing surgery, we should see a 14% reduction in blood transfusion across that set. If we go for a 1 day length of stay reduction and we reduce complications by a similar amount, which is 4%, this is in 180,000 patients, this is how the numbers add up. So this is the teamwork that's involved in setting up a trial, and naturally we have the British cycling team, far superior to the Australian cycling team. And I know the Australians will only argue that we're good at sitting down sports such as horse riding, rowing and cycling, but nevertheless. What you can see here is it takes a huge amount of work to set up a trial. We've got a series of experts on the panel. Ian McDougall, who's well known in the world of iron therapy, particularly in renal dysfunction. Stefan Anker, who led the FAIR-HF. A variety of lay members. And crucially, we have endorsement by the Blood Authority in the United Kingdom, which is NHS Blood and Transplant. Any further questions, please don't hesitate to email me.